Welcome. This activity is intended for U.S. healthcare professionals only. The following presentation from Answers in CME is part of an educational activity titled A Shared Vision on Diabetic Macular Edema Management, Improving Outcomes with Long-Acting Anti-VEGF Agents. To access the full program and supporting materials and to claim your certificate, please visit the activity URL in the episode description. This activity is supported by an independent educational grant from Regeneron Pharmaceuticals Incorporated.
Welcome to this CME activity, where we'll be discussing improving outcomes in diabetic macular edema with second or third generation longer-acting anti-VEGF agents. My name is Nitish Mehta. I'm on staff at NYU Langone, where I serve as an assistant professor of ophthalmology. I'm here with one of my good friends, Dr. Sarwar Zahid. He does serve on staff at NYU as well, but he's also the founder of Empire State Retina.
Thank you for the introduction, Dr. Mehta. What are the treatments that we have available for diabetic retinopathy, specifically for diabetic macular edema? I usually start with an anti-VEGF. I go to intravitreal dexamethasone quite early if I don't see a good response or if the edema looks chronic. I use focal laser uncommonly, but especially if there's a succinate ring of exudates. Dr. Mehta, what do you typically do?
Intravitreal anti-VEGFs, they have a very good safety profile and do work quite well. I think it's important to recognize that steroids and other laser procedures still play a role in the management of these conditions.
The burden of treatment is quite high. Patients usually have to leave work to make their appointments. A lot of our sicker diabetic patients often come with caregivers. So these are additional people that we have to consider when figuring out a frequency of treatment and the frequency of injections. DME patient appointments are often canceled, but get the amount of no-shows. So 10% versus just over 3% of no-shows for AMD. Dr. Mehta, any thoughts on appointment compliance? Is this something that you notice in your patient population too?
The DME game is a long game, right? Compliance and no-shows have a pretty significant deleterious effect on their long-term visual outcome. We need to be able to create an experience for these patients in which they come less frequently, but they stay with the program.
In year one, patients get about 4 injections. ETDRS letters gained is about 3 letters. Over time, the number of injections goes down, and those visual acuity ETDRS gains dissipate and nearly disappear with time. Dr. Mehta, do you want to talk a little bit about the timeline of FDA approvals for anti-VEGF in DME?
In the mid-2000s, it became clear that vascular endothelial growth factor therapies could be utilized in retinal vascular disease. And so for quite a while, compounded bevacizumab is used as an initial agent of choice to reduce the amount of exudation that occurs in diabetic macular edema. Then in the early 2010s, ranibizumab and aflibercept allowed for Q4-week treatment in terms of ranibizumab and potentially up to Q8 weeks for aflibercept. This revolutionized our care, yet required frequent trips to the clinic. Treat and extend was kind of born out of that. Newer agents, including brolucizumab and faricimab, hit the market. So now you're able to be on label and treated up to 16 or Q12 weeks. Brolucizumab, unfortunately, came across a couple of post-marketing safety issues, increasing the molar dosing of aflibercept. This is where we are as sort of the state-of-the-art treatment now for diabetic macular edema. It's also worth mentioning the port delivery system, a surgical implant of ranibizumab for up to 6 months without a refill.
In the next session, we'll discuss the efficacy of the long-acting anti-VEGF agents for DME.
So for DME, for aflibercept 8 milligrams, the study is called PHOTON. In this study, they were randomized to be able to receive 2 milligrams aflibercept versus 8 milligrams every 12 weeks or 8 milligrams every 16 weeks. The end of the study was 96 weeks. There's an optional 1-year extension. The patients who were assigned to the 2 milligram arm were treated every 8 weeks regardless. They were not allowed to extend. So what you're testing here is extension ability of 8 milligrams compared to monthly 8 weeks 2 milligrams. All of the arms are doing quite well at maintaining visual acuity gains. And in the 8 milligram arms, they're being injected less frequently. We can see the anatomic results, central retinal thickness being that surrogate marker for retinal edema. And you can see that the 8 milligram arms are able to perform just as well as the 2 milligram arms at less frequent dosing. And here we have the two seminal phase 3 clinical trials called Yosemite and Rhine. So here you have patients that are receiving 2 milligrams Q8 weeks. You have another arm that is receiving 6 milligrams of faricimab at a fixed Q8 week dosing. And you have another arm that's receiving faricimab 6 milligrams on a personalized dose treatment interval arm, which is essentially your treat and extend. And all of them are receiving some degree of initial loading doses. Treatment frequency is based on a combination of both their vision and their anatomy, which is the central subfield thickness. In terms of visual acuity, the 2-year data is showing gains across the board. And of course, gains in the faricimab arms, and especially in the treat and extend arm, are able to be maintained with less number of injections over time. Central subfield thickness is also maintaining a very nice downward sloping. So in this next session, we'll actually go into how we personally go about dosing patients with anti-VEGF agents.
Well, let's quickly review the different available anti-VEGF therapies for DME. Let's start off with bevacizumab. We use this medication off-label, usually every 4 weeks. Ranibizumab, typically also used Q4 weeks. Brolucizumab, 6 milligrams, is typically Q6 weeks for the first 5 doses, and then between Q8 and Q12 weeks. Aflibercept for 2 milligrams, it's typically Q4 weeks for the first 5 doses, and then Q8 weeks. If for 8 milligrams, Q4 weeks for the first 3 doses, and typically extending out to Q8 to Q16 weeks. And finally, faricimab, 6 milligrams, is typically administered Q4 weeks for 4 or more doses. If there's resolution of edema, then typically we extend these patients out to 16 weeks. But how do we decide when to extend the treatment interval? So after what we call loading doses, based on the response, we extend by 2 or 4 weeks. But what are the criteria for extension? First off, absence of intraretinal fluid or resolution of intraretinal fluid, resolution of subretinal fluid, and improvement in visual acuity. If there's active disease, such as persistent fluid, persistent poor vision, or a recurrence of fluid upon extension, then we typically shorten the treatment interval.
Fluid volumes were combined into something called central subfield thickness, and that is your biomarker of retinal exudation. There are subcompartments within the retina. So we think of the cyst form, that's intraretinal fluid, and sometimes you'll get a neurosensory detachment and you will get subretinal fluid. What this study has shown is that, yes, if you have a lot of subretinal fluid at baseline, you're going to have very poor vision, but fortunately, you tend to have a very good visual response. When it comes to intraretinal fluid, the story's a little bit different. If you look at the post-hoc analysis of Protocol T and Protocol V, both fluid sources were shown to have negative visual outcomes, but fluctuation of CST or fluctuation of vision over time is worse. Thus, if you do see small amounts of residual intraretinal fluid, you should say, hey, we really need to knock this out. This is not the time to extend.
Let's talk a little bit about the Photon trial and the Yosemite and Rhine trials. Photon is the DME trial for high-dose aflibercept. And what's really great is that basically in all 8 milligram patients, about 89% of patients were able to extend to these really long intervals. So now looking at Yosemite and Rhine, over 50% of patients were able to get out to Q16 weeks. So these are very long-lasting and durable medications for both these medications. In the next session, we'll discuss patient selection and counseling.
What are the patient-related factors when considering to select anti-VEGF therapy to treat diabetic macular edema. At the core of it is going to be the patient. You're trying to make their visual experience better, but patients may not enjoy getting injections or want them or understand their value. They may have other medical conditions that make it very challenging to be in clinic. Oftentimes, there's a significant amount of wait time in our clinics. They may not have the resources to show up at all, be it just someone to pick them up and drive them. The data has shown us that you are likely to get more durability with a second generation agent. The jury's still out at the end of the day if a patient is receiving more frequent injections with a first generation versus less injections on a second generation agent, whether the efficacy of that treatment modality matters at all. But most people would like to get less injections over time. How do I actually go about introducing an intravitreal injection to a patient? We're talking about people's eyes here. They're one of the most sensitive parts of the body. I always tell people this should not be traumatic. We can find a way to make you comfortable. The eyes can be numbed very well. Artificial tears are therapy and they work extraordinarily well. In the beginning, I put them in the eye for them and I teach them how to do it. We need to discuss that this is going to take a very long time, that every single visit, we're going to make a nuanced decision on when you need to return, and we're going to be doing this for a fair amount of time. There are obviously very significant things that can occur as a result of an injection. It is an invasive procedure. I like to break it up into things that are likely to happen, which is transient red eye, transient eye pain, potentially transient blurry vision and tearing, but things should generally continue to improve. If within the first week you notice that vision is decreasing, pain is increasing, and floaters are increasing, give us a call, come back in. IOI, which is this strange inflammatory reaction to the drug molecule itself, does come up periodically. They're going to be slightly more delayed to typical endophthalmitis, but this is another thing to just keep in the back of your mind as something that could occur. It's our job as physicians to communicate with the patients very clearly that just sticking with the plan is what's going to work. And the easier we can make the appointments, shorter wait times, less number of injections over time, and a pleasant experience can help us increase that compliance. So in the next section, we're going to discuss adverse events management and long-term care.
What are some of the adverse events that are associated with anti-VEGF therapies? Subconjunctival hemorrhage, eye pain, floaters, IOP increase. These are the common things that we see in patients. The more serious adverse events that we worry about are things like cataract formation, thankfully very uncommon, endophthalmitis, retinal tears and detachments, retinal vasculitis, and uveitis. Dr. Mehta, each of the studies have shown different rates of IOI in each of these agents. Do you have any thoughts on what we should look out for?
When it comes to distinguishing endophthalmitis from intraocular inflammation, the clinical signs that we're looking at are relatively similar. So anterior chamber inflammation, plus minus hypopyon, plus minus vitritis. In general, if there's vitritis, my concern for endophthalmitis is fairly high, and presumptive treatment is likely going to occur. Endophthalmitis with just treatment of steroids is going to get worse. And so our index of suspicion for treating infection is going to be rather high. In general, 1 in 3,000 for endophthalmitis, much rarer for IOI. When it comes to IOI that has occlusive vasculitis, the patient is going to lose vision and there's no way out of it. With endophthalmitis, if caught quickly and treated appropriately, there is a reasonable chance that we can preserve, save, or improve vision. And I think that's why the line is drawn very differently when it comes to endophthalmitis versus occlusive vasculitis.
With endophthalmitis, there's typically pain, and the mainstay of treatment is intravitreal antibiotics. But the intraocular inflammation presentation, in my experience, has been sort of a little bit of ocular discomfort, a little bit of redness. Floaters are pretty common. And the treatment typically includes intravitreal antibiotics because our index for suspicion is very high for infection.
Yeah, if there's pain, you're really pushing on the endophthalmitis side of things. If it's mild AC cell, you could treat it as IOI. But if there's a hemorrhagic occlusive vasculitis, that's probably actually not endophthalmitis. And I think that's the differentiating point.
We are always deciding when to switch a patient from one medication to another. Dr. Mehta, do you use any specific factors or deciding to switch?
There are so many different factors that go into it. Just be very observant and keep your mind nimble. And if the fluid's getting a little bit better and the vision's looking stable and the patient's doing well and functioning, then yeah, stick with it. But if there are enough red flags on the patient, the vision's not as good as you'd expect, you're starting to see the OCT is not as good, make a change.
Having an individualized treatment plan, utilizing all these different medications that we have available to us are some of the main take-home messages. Another is that we need patient buy-in. This is a chronic condition. One of the things that I tell all of my patients is, look, you may need injections for the rest of your life. And to get buy-in from patients is the most important thing. Thank you so much, Dr. Mehta. That was a great discussion.
Thank you. Always a pleasure to discuss patient management with you.
Thank you for listening. Please visit the activity URL in the episode description to view all program materials, complete the post-test, and get a certificate.